All right, Mike, we have started recording here. I imagine some people will join in again. Um,
Okay.
Still there, Mike? Yeah, there we go.
All right. So I put together an update for this virus. Maybe some of you have heard about. There's let's see. Okay. So if people haven't seen the Johns Hopkins website, it does provide a good world overview. It's updated pretty closely to the United States data. This screenshot I took on the 13th kind of shows the world burden right now with 1.8 million cases confirmed. That's over 2 million today. The total deaths of 116,000. If you look, the United States unfortunately is really leading the number of cases with more cases than Spain, Italy, and France combined. A huge proportion of that is confined to big metropolitan centers, and it disproportionately has affected those. It's hard to interpret this data, determine what's going to happen locally, and we'll kind of talk about that some more. But this is a good website if you kind of want to. I kind of check it like daily to kind of see where things are with the international situation. In the bottom corner, you guys can see my cursor, I think, right?
Yeah.
It's showing the kind of, the number of cases. You can plot that out logarithmically. Oops, sorry, back. I forgot that's not the active website. You can look at the logarithmic data, and it looks like there's kind of several plateaus that occur with that. It'll also show you like the number of daily cases, which has gone down slightly. The United States specific cases, on the 13th, 547,000. This morning, that was over 600,000. A huge proportion of those in New York and the surrounding areas. But then additional, significant number of cases now around Florida, Los Angeles, Chicago, and still in the Seattle area. The Montana data, this was pulled on the 13th as well, and shows kind of our total cases. It plots out cases per day in the bottom right corner. The cases per day have kind of been declining recently, which is good. But we've not done that many tests right now. The state lab has increased the number of tests they can do per day, and that number right now is around 250 cases or tests that the state lab can run per day. Now, those test turnarounds are 24 to 48 hours. By county, looking at this, a huge number of people traveled into Gallatin County, which is why they have disproportionately such a high number. We're doing relatively well considering we're on Interstate 90 with only 30 cases in Missoula County. We had a couple additional cases today. Looking at models that kind of predict what's going to happen. This is kind of a hospital resource use prediction, and this is for U.S. data. This was on the 11th, and it shows kind of where we're where we're at currently, as well as the number of ventilators needed projected. Goes up to almost 20,000 there, with an error bar that doubles that amount. Number of all beds needed projected, 82,000. Again, looking at the error bar for that, it goes up to 3 times that amount. So these models are kind of subject. Small changes in data can dramatically impact what these models predict. If you've been following these, like several days ago, the Montana one, went from needing 89 critical care beds down to like 12 critical care beds, and it was because the state didn't report numbers over the weekend. So those small changes in the inputs to these can dramatically affect what these models look like. So you can see that this gives this is the U.S. prediction. This gives a bed shortage in U.S. hospitals of 12,000 beds, ICU bed shortage of 8,000 beds. It's tough to come up with those additional beds in a crisis, And it looks like a disproportionate number of those shortages in ICU beds, hospital beds, and ventilators are going to be in metropolitan areas. So this is projected deaths per day, and it shows our actual there, followed by the predicted. Again, this has huge error bars, ranging from, 2,000 predicted right now to, up to, more than twice that per day. And, who knows how far out that extends. This is the, again, the total deaths for the United States, projected 61,000 if we stay on the curve where we're at right now, but, could be, over 140,000, maybe less, but it looks like this number is going to, continue to rise, and we just don't know where it's going to go or where these peaks will occur. A lot of these models, change based on our social distancing practices. So when we make those kind of changes, the lag on these models to see if they're effective is around 2 weeks. So if we, remove social distancing, we may not see those effects on actual cases as well as how it's affecting the models for 2 weeks. So there's a lot of lag in this. So these are the Montana data. This is, they're saying that we're peaking around April 20th here, that we'll have, no bed shortages in Montana if we're at capacity, and, no ICU bed shortages. These numbers are kind of variable. It doesn't account for all the ICU beds, but may, this is the whole, looking at the whole state. But again, if different metropolitan areas are disproportionately affected by the amount of ICU beds and ventilators, this could easily overwhelm a single system. Like Gallatin County, is running at really high capacities right now, while we're actually really low. So these numbers, again, may not reflect the local situations that occur, especially if we were to get like a vulnerable population infected, like at the jail or the Poverello Center or Riverside, Hillside, something like that, where we have a bunch of people who would require high amounts of care and have a higher predicted mortality. All these numbers could dramatically change. So right now, based on this model, it looks like we're sitting fairly good. This is the peak deaths per day. You can see that this model already doesn't predict what has happened currently. So we have, it's hard to know where these numbers will go. And the error bar is fairly huge. Thankfully, with our lower population, these numbers are lower than a lot of other areas that have really dense populations with a lot of people. So, and again, this is the Montana specific predictions for number of total deaths, ranging around just over 40 to, 50 deaths per day. But again, the error bar up at more than 200 total. So kind of a wide range. So the coronavirus itself, we'll just kind of go back to review this. Not that this is super important, but it's a small RNA virus. There are other viruses in there, are the common cold, SARS, and MERS. And this SARS-CoV-2, which is the COVID-19 illness virus, is very closely related to SARS. They bind the same ACE2 receptor on the surface of cells in the GI tract and the lungs. And so that it got SARS-CoV-2 name because it binds the same receptors and has a lot of similarity. It has the really short RNA genome, and it doesn't require super accurate transcription, which allows for it to mutate pretty quickly. And you can see, I'm sure you're all following this diagram really closely, about how many different varieties of this are. The purple represents the original virus that branched into 3 separate morphologies, and then a subset branched off that top purple line into the ones that we're seeing outside of China now. So there's a lot of different types of this. There's 2 main types: the original, if you will, the purple virus, and then the green virus. So We don't know how the different viruses will express themselves as far as differing symptoms or severity. In general, over time, these types of viruses, the illness tends to become less severe so that it can be transmitted without killing the host as often. Um, the Yeah, so I think that that's kind of one of the big advantages of social distancing and, you know, keeping the curve flatter, is that it gives time for the virus to mutate and become less severe. We don't really know what that's going to do to this long term, however, though. What might happen is that you end up with a reservoir in the community, and this becomes another yearly influenza, um, or, you know, we end up having a delayed peak in the fall because we have a huge portion of the community that's not been exposed, and we have this persistent infection level in the community, and then we get a peak later when social distancing is restricted because it's not tenable to keep that up, you know, indefinitely. So transmission, there's a lot of discussion about this, but primarily this is spread by a large droplet, and that's things that are greater than 5 micrometers. For example, your N95 mask is it has like a filtering uh, size of around 3 micrometers. So most of these you know, things will get filtered out by actually just a simple surgical face mask. The N95 is probably overkill for most things. You know, you need to be within close contact, which they define as less than 6 feet for a prolonged period of time, and they define that as over 10 minutes to really be at high risk without any protective equipment for, you know, spread of this. And then contact with fomites is actually probably as big a risk. So, you know, getting this on your face, it creates a thin biofilm. You touch your face, you touch a surface and touch your face, and eventually get contact with your mucous membranes. So those, you know, large droplet and contact with those, you know, fomites are really the greatest risk for transmission. And that's why, you know, simple face mask on the patient for source control, as well as on yourself, in addition to frequent hand washing and wearing your protective equipment appropriately, is the best way to prevent transmission. If you look at these EMS units that were unloading symptomatic people from cruise ships, they actually reported no providers developing you know, a nosocomial infection with this virus, and they were using just simple face masks or N95s only for aerosolizing procedures. So I think that's pretty encouraging. When we generate aerosols, we do need to be concerned about this, and we should be wearing, you know, a face shield in addition to an N95. The face shield is important because that, you know, protects our eyes. In addition, I think wearing a pair of glasses underneath the surgical or the face shield is the most appropriate. Actually, we worry about this in the EMS realm primarily for nebulizers, non-invasive ventilation, oral suctioning, intubation, and bag valve mask procedures. So we're now recommending we use that level of precaution for, you know, any patient that requires this right now, because there is some community spread, although the prevalence in our community is very low. Incubation, so they give a range of 2 to 14 days, and a lot of that is based on data from SARS. Actually, looking at the COVID data, the rates of the the most common incubation period, sorry for that, is 5.1 days for the COVID-19. You'll see like patients essentially asymptomatic until that 5.1 day range. Maybe it's around 4 days if you're measuring if you're checking these rapid PCR tests. So 4 to 5 days. You have a window there after exposure before you're actually symptomatic. Once you develop symptoms, it looks like, it takes about 6 days of being symptomatic to develop dyspnea, and 8 days for admission to the hospital on average, followed by 10 days for admission to the ICU. So it's not like when you first get the symptoms, you're critically ill. You have some time before you know if you're going to start developing worsening symptoms that require hospitalization or admission to the ICU. So again, the clinical presentation is really nonspecific, constitutional symptoms, which are just like malaise and not feeling well, upper respiratory symptoms, lower respiratory symptoms, GI stuff, myalgia, fatigue, or, some of these people have been documented not to have any symptoms at all. 50% are going to be febrile at presentation, and that goes up to 80 to 90% over the course of their illness. The cough is the most common other symptom besides fever, dyspnea in 31%, and there may be some more GI illness in this than initially thought. The data from Everett suggests that they were having more GI symptoms, up to 20-some%, but mostly the documented rate of GI symptoms is around 10%. A lot of these patients are going to have chest pain too. It looks like once they start getting sick enough to require the hospital, they develop thickening of the lining of the lung and pleurisy. So, important questions for us to be asking is if they have, pain with breathing, because that can indicate that that can be one of the symptoms on there as well. So, risk factors for severe illness. In general, over the age of 55, more common for severe illness. There may be some risk for male gender, and they don't know exactly why that is. Hypertension is probably a risk factor for severe disease, lung disease, cardiovascular disease like stroke and coronary artery disease, peripheral vascular disease, diabetes, and then immune compromise I didn't put on there necessarily because there's debate about how much of a risk that is. They do think that some of these people with immune suppressing medications for things like rheumatoid arthritis, psoriatic arthritis, other autoimmune diseases, they may be protected somewhat from severe illness because the kind of medications they're on prevent some of the autoimmune host response that generates, worse symptoms.
Hey, Mike, those are risk factors for severe illness or just for illness?
For severe illness, for being hospitalized. So the clinical course. So Everett put out a whole bunch of stuff recently on what their mortality looks like, and LSU from Louisiana. And they, in Everett, they're reporting, 25% mortality for all hospitalized patients. Everett's ICU mortality was about 66% if you went to the ICU. LSU is reporting about 45% though, and they're reporting that they're extubating about 45% of these patients from the ventilator, which is better than most other places. Again, survival's better if you're younger with less comorbidities. Survivors to discharge had an average age of 49. That range was, 25 to 75. Required the ICU was, patients 63 on average. And then the patients who died averaged a higher age of 72. So what we're doing locally, 911 is trying to screen calls. I think they're doing a pretty good job. We've had, expected confusion in there, but anyone with fever, any complaint of fever, I think, and it doesn't have to be documented by us. Any respiratory symptoms, so cough, shortness of breath, respiratory distress, respiratory arrest, those things we should be using droplet precaution. And then I put any generalized illness. So I'm really feeling poor. I got, muscle achiness. I'm just not feeling well. We should think about using these droplet and contact precautions. Travel is probably less important. I guess if they say they just flew from New York, or I would still ask, but it's probably less important when there's community spread. And then still trying to determine if there was close contact with a laboratory confirmed case is important. Any arrest, we should be using airborne precautions with the N95. And then we need to, 911 should be communicating that to us before arrival if they can. So I still think we should begin all assessments at 6 feet, and we should, follow standard procedures if COVID's not suspected. I will say that it's reasonable probably at this point to, wear a mask for all these encounters and put the patient in a mask if we have the PPE available. And that's the change in recommendation currently. if we get that pre-arrival from 911, or we develop that suspicion during our 6-foot evaluation, we need to don our PPE. We limit the number of exposed providers. Have the patient don the surgical mask. They can wear that over a cannula. They can wear it over, some vented face masks as well. And we should have, eye protection, goggles, or preferably face shield, surgical mask or N95 for aerosolizing procedures, gown, and I prefer double gloves, but if we don't have them, it's all right to use single gloves. We go through donning training in the emergency room once a day. They have someone from infection control come down and put that on for us. I think it's reasonable to review this at every shift, and I would recommend having a officer who basically is checking people who are taking off their PPE, because taking off the PPE is really the most important part. I think a lot of people forget to do the hand sanitization over the gloves. Remembering to, decrease any viral load that might be on the gloves before you start taking your PPE off. Try not to touch the front of your mask or face shield. Remove your gown without touching the front of it if you can. So he shows him here untying it, but it's best to break the gown from the front and then fold it into itself. Hygiene, again, trying not to touch your face. Hand washing for 20 seconds with soap and water, or 60% ethyl, 70% isopropyl alcohol is the guideline. So as far as clinical management for us, a lot of these patients do not require hospitalization, the majority. I think we should be continuing to follow the non-transport guidelines as they're appropriate. People who need to go to the hospital still need to go to the hospital, but if they don't and they fit those guidelines we put out, which if anything are conservative, I think trying to get signed consent to not transport is very reasonable, and using online medical control. The providers at St. Pat's are all aware that that's a call they may be getting. So minimizing exposed providers, it sounds like we're doing a good job of that. Don't delay care. If someone is critically ill, we still need to put our PPE on, but if we're waiting for MESI to respond because of high volumes, then fire may still need to go in first if needed. So, or if you guys get in there and realize that you have someone who's sicker than anticipated, call them in, so you guys kind of have that backup additional providers. A lot of these patients need supplemental oxygen, and starting with 6 liters by nasal cannula and escalating to a non-rebreather at up to 15 liters, none of those flow rates are considered aerosolizing. So the big change I put in here was to allow recumbent positioning. So it looks like for a number of reasons, these patients have increased dead space in their lungs, and that can be from atelectasis, where they have collapsed air alveoli that are perfused, but they're not ventilated. So that's VQ mismatch. And they also have increased dead space, probably from little blood clots, microvascular blood clots in the lungs. So that allows you to have areas of the lung that are ventilated, but not perfused. And that combination of VQ mismatch and dead space is a big reason for why they develop so much respiratory distress, why they're breathing so fast. And allowing them to change position from just being on their back to rolling to a side, or even prone, which is where they lie face down, may significantly improve those VQ relationships. In the ambulance, it's difficult that we don't really have a good way to allow someone to position prone, but letting them roll to a side, like flattening the gurney out and letting them roll to a side, is very appropriate. So as opposed to like regular pneumonia and sepsis, where we want to fluid resuscitate these people, we want to avoid aggressive fluid resuscitation. And actually they've shown survival benefit from this trial called the FACT trial, to where they're actually diuresing these people to a slightly negative fluid status in the ICU. Don't be pumping these patients full of fluid. If they have tons of volume loss and they're hemodynamically unstable, not just tachycardic, but their blood pressure is low, then I would consider, judicious fluid boluses, like 500 mils at a time. avoiding steroids is probably good. It looks like there's increased mortality if you're using steroids in these patients. If they have asthma or COPD and they have a lot of wheezing, we're still using them because those patients still need that benefit. But there's some thoughts about treating acute respiratory distress syndrome with steroids, and that's been shown in these patients to have worse outcome. Using an MDI with spacer instead of nebulizers, I think, is a good idea if we have them available. You can use 4 to 6 puffs in the air chamber and have them breathe through that. They want to breathe all the way out before they start inhaling through the air chamber. If you still need them to do a neb and you have no other choice, then you may have to do that. I would try and do that outside of the ambulance if possible. If not possible, that's definitely an aerosolizing procedure. You need that PPE on. I would consider more aggressive use of subcutaneous epinephrine as an option, specifically for asthma, but I think it's also reasonable for COPD as long as they're not super tachycardic. They may benefit from that if you can't give them, adequate nebulized.
Like, is there a reason that's sub-Q versus IM for this particularly, or?
I think it says sub-Q in there. You could use IM as fine, to be honest.
All right, fine.
So if we have to bag someone, I think we want to make sure that we're using the viral filter between the mask and the bag valve mask. This is probably a 2-person procedure, so you have one person doing the double thumbs down technique to pull the jaw up with the fingers into the face mask, and a second person bagging to generate the best seal possible. I would use your PEEP valve. Normally that's set at 5. I would consider using 8 to 10 to start for these patients because they probably benefit from increased PEEP. We don't want to milk all the air out of the bag either. We should be thinking about using these low tidal volume ventilations. We can't really measure that with the bag valve mask, but squeezing the bag with one hand will prevent you from delivering 1,000 mils versus the one hand you tend to deliver around 400 to 500, which is for an adult male about where we want to start. Using the supraglottic airway for airway management, I think is probably preferred. It decreases the duration we're performing the procedure, and it increases the distance away from the patient we are while we're performing it. So I think it carries less risk than endotracheal intubation. We don't have the ability to do RSI in our system, so that carries risk with it as well. And I think that this is a very reasonable way to do it if the patient's able to tolerate a supraglottic airway. We still want to connect the viral filter directly to that airway. So we probably want to have that on the bag valve mask that we had initially, remove the mask and connect that directly to the supraglottic airway as soon as possible. Putting the end-tidal CO2 device in line beforehand. So you go mask, viral filter, end-tidal CO2, and then bag valve mask is how I've been doing this, and I think is probably the preferred way, so that it's already plumbed and connected to your monitor, and you can look directly for waveform as soon as you have the supraglottic airway in place. If we're not able to keep saturations up, we talked about the low volumes for these patients, but we want to make sure that we're increasing the PEEP setting on that bag valve mask. If we're having trouble maintaining SATs greater than 92%, we'll probably be using 100% FiO2 with this, just by virtue of the bag valve mask and not being able to adjust that. So those are kind of the primary things I was going to put in there for clinical management. Transport, we want to notify the receiving facility early that it's a patient that has droplet precautions. Again, family members shouldn't ride in the transport vehicle. If there's no other option, they need to wear a mask. We want to try and isolate the driver from the passenger compartment. Try not to contaminate the driver compartment as well. The ventilation inside the vehicle is limited, but we don't want to use recirculated air. If we have vehicles that have the HVAC systems in them, those would be the preferred vehicles to transport these patients in that are known or suspected. Cleaning of the vehicles, during the handoff, and we want to keep those doors open to allow air to circulate and any droplets that are in the air to settle. probably around 10 minutes is adequate. They say wear gown and gloves as a minimum, and a face shield or face mask if splashes are expected. I think I would, definitely do that if you did any kind of aerosolizing procedure in the back, because that 10 minutes may not be quite enough to get all that air to turn over. You definitely want to wear appropriate PPE in there. The way we're handing people off at St. Pat's too, you'll be able to keep your PPE on, so you don't have to don a second set of PPE to clean the vehicle. I think the ambulance bay handover is going well, and that's the best way to minimize, doubling PPE use for patients. And it's also the best way to transport a patient through the hospital without contaminating the hospital itself. So if people aren't familiar with the setup of room 5 at St. Pat's, there's a direct entrance from the ambulance bay for anyone who's like critically ill with suspected COVID or any cardiac arrest. Going directly into room 5 gives us the ability to avoid coming through the emergency room with ongoing aerosolizing procedures. We kind of have special policies for transporting patients within the hospital with those ongoing, but if we can avoid that, we have negative pressure in room 5 now. It has different settings, so if we're actually aerosolizing, we can set it on a high setting. For patients getting CPR, we've decided to go with the pup tent and sheet from the ambulance bay. That allows the person to, bag by squeezing the bag through the sheet. An intubator can still intubate that patient underneath the pup tent portion of that, and it protects the person doing CPR. So let's see. I put in the respiratory disease protocol. We've all kind of seen this. There's no big changes to that. And then the exposure flow chart, which I'm not really going to go through a ton. Just be aware that these are out there and this is what we're using. We should be using goggles or glasses and a mask at minimum for every patient right now. And then anyone with suspected COVID, we should include the gown and the face shield. So we also have kind of a what to do if you're symptomatic. So you had some at-risk exposure or you did not, and you develop a febrile illness, cough, or shortness of breath. You need to self-quarantine immediately and contact your supervisor. You need to contact a healthcare provider through probably Grant Creek or the CPG North Clinic to arrange screening or evaluation for whether screening is necessary. If you have a positive test, again, you want to self-isolate and follow the health department instructions that you'll get. If you're sick enough, you think you need to be in the hospital, you should come to the emergency room. So if you have a negative test, you still need to self-isolate and follow those instructions until you've been asymptomatic. And we had specific guidelines for that. So that's like, I think, what did we decide, Dave? It's 7 days from the onset of symptoms. And then with having 3 days of being asymptomatic without cough or fever or respiratory symptoms. So the minimum time would be 7 days, that you would be out, maybe closer to 14, depending on your symptoms. So let's see here. I don't really have this. I just threw these in here. Are there, I guess I'd open it up to questions at this point. I can, yeah, so go ahead.
Mike?
Yes.
So what kind of treatments are being done at the hospital for these patients? Are they using the plasma from previous COVID patients, or are they using the Core-9?
John, I'm not able to hear you. I'm sorry.
I'll type it in.
He asked what kind of care is being done in the hospital for these patients.
So within the hospital, we have a flow for what looks like. I'll actually bring that up so you guys can see it. This is something I built with the intensive care doctors. just to have a, let's see if I can.
They're coughing.
You saw that. All right. I'll share my screen again if I don't screw this up. Can you guys see that?
No.
Okay. How about now?
Yes.
Okay. Let me make this so that it's more readable. Sorry. Okay. Not sure why that's too big.
How about on the bottom right there, Mike, where it says 180?
Oh, yeah, thank you. Sorry. All right, so this is kind of a flow of how we're doing things at the hospital. So we have suspected or confirmed. If their SATs are less than, 92%, we're putting them on a nasal cannula. If they're in, they have severe hypoxemia but mild distress, we are doing high flow nasal oxygenation, and our initial rates are 30 liters per minute by a special high flow nasal cannula with up to 100% FiO2. And if they're not decompensating, these patients are going to be admitted to the ICU. If there is critical shortage of ICU beds and we reach crisis standards, these patients might go to a floor bed. We monitor them really closely every 30 minutes, and if they develop rapid deterioration, hemodynamic instability, this ROC score is a score that evaluates how effective the nasal oxygenation is. They have persistent elevated respiratory rate or dysynchrony, this abdominal dysynchrony. They would go to an intubation protocol, which we run through a whole checklist. We only take certain things in the room. We only allow 4 providers in there. So there's an intubator, there's a respiratory therapist, and 2 nurses. And then we have a pharmacist, another doctor, and an outside of the room runner outside of the room. And we're using these lung protective ventilation strategies for those patients, and they'd go to the ICU. So if they're minimally symptomatic and we're able to keep them on 6 liters, they'll go to the the hospitalist service to a COVID cohorted area, and right now that's 4 South at the hospital. So they have additional monitoring capabilities, and that's only for suspected or known COVID patients on that ward. If they need more oxygenation than that 6 liters per minute,
Hey, Mike, I don't know if you can hear us, but you cut out there.
Looks frozen.
Yeah, no, I can see them. I'm just going to give them a call.
Can you hear me?
Going to 1,000. Thanks, Jeff. Beer ball.
Hey, Mike, your screen is for, there we go. I think you're coming back. Oh. All right, Mike just lost his network connection, so we're just waiting here.
Okay.
Okay, so minimum matching all for every COVID-19. So everybody's going to mask.
Yes, exactly. Permanently do away.
That's actually tizzy.
Shows up on there.
It's not mild. Bob got it started up and he fell asleep and I was in there. Tizzy's watching YouTube videos.
Hey, back boy.
I kill my owner. Yeah.
Hey, Mike just lost his internet connection. He's just getting back on, so we'll wait here.
Don't scratch your face.
Can you guys hear me at all?
Sorry, but it's allergy season.
Oh, look at that. There's no allergies. It's all snow.
Crazy.
Hey, Dave, can you hear me at all?
Don, is that you, Don, talking?
Yeah, can they hear me at all?
Yeah, we can see your desk.
Hey, just so you guys are aware, it's really, really important to get your trip reports done as soon as you can on these COVID-19 calls. So I track every droplet call. I look at them every day. And then I get off of your report, I get the patient's name, date of birth, stuff like that. And I get it to both hospitals and they let me know whether they were tested or not. And then the results of their test. So far, we're at about, I think about 106 droplet calls and we've had 0 patients test positive. So far we've been pretty lucky, but
Let me,
please do a good job of
I'll
keeping
ask.
reports in.
hey guys, so Mike's transformer up by his house just blew out, and so I still have him on the phone. What other questions do you have for him?
Did we ever, you guys are talking about before the meeting, Dave, about CPR stuff, so can we address that at all, or where are we at with that?
Mike, can you hear that? Do you want to address CPR stuff?
What was that?
The question from Jeff is any CPR updates or anything.
Do we have, are we all set with the updates we're planning, Dave?
We're not quite there yet, I don't think. Just wondering from you whether you wanted to, we're going to do anything different with.
So I was kind of waiting until we had this full document done, but basically what I think we should be doing is we should be using, full PPE, including N95 masks for any cardiac arrest. The next portion of that that's important is that we want to minimize any exposure to aerosolization with these procedures. That's part of the reason we're going to go straight to supraglottic airway, and I might manage the airway earlier than I normally would during what we've been doing for pit crew CPR. So making sure we're inserting the supraglottic airway, staying as far away from the patient as possible, and going directly to BVM with viral filter and inline end tidal CO2 for that procedure. The next portion of that is we are considering, and I think probably going to recommend going to Lucas device earlier as well. Potentially we could time putting the back piece for the Lucas on while we're inserting a supraglottic airway really quickly. Doing that would allow us to do mechanical CPR that would, limit exposure to providers during that process. Additionally, I would recommend, not continuing chest compressions through the airway attempt like we would normally do, so that we're not, again, aerosolizing while we're putting that airway in place. The other recommendation, I've seen a couple of different recommendations so people know. Some systems right now are not starting or discontinuing CPR if it was an unwitnessed arrest by bystanders. So they found the person in cardiac arrest, and when they arrived there, that the initial rhythm is asystole or PEA less than 40. I think probably most appropriate right now is that if it was unwitnessed by the caller and the patient is in asystole when you get there, you probably don't have to continue any efforts. So,
would you like that to be an online medical control, just confirmation, unless there's obvious stuff like rigor mortis or lividity?
Yeah, I think that's reasonable right now, and I can put that out to the St. Pat's group so they're aware of that recommendation. I don't think there'll be any pushback for that. Looking at what Seattle's doing, they're saying that they're not significantly altering their stuff. They are not transporting any patients in cardiac arrest in Seattle right now, and that's been their protocol before this. So I would have I would have a higher threshold to transport a patient with ongoing CPR, and I think that again would be the patients who may have PEA at a reasonable rate that you think maybe just severely hypovolemic from like blood loss from a GI bleed or something, or patients that have refractory VFib. So you've done 5 rounds of shocks and they're in persistent VFib every time. Again, that might be someone I would transport with ongoing compressions.
Great. Anybody else have questions for Mike?
I have a question. Can you hear me?
Yeah, go ahead, Kit.
Yeah, just initially, do you still want us to put a nasal cannula on the cardiac arrest patient with the OPA, with the apnea oxygenation, or?
Did you hear that, Mike?
Yeah, I think that's still totally reasonable. The nasal cannula at any flow rate we're able to deliver will not be considered aerosolizing. The only difference is I would probably discontinue the source of oxygen during the supraglottic airway attempt. So I would probably turn that oxygen off while I'm putting the supraglottic in. But putting that on them initially is fine. So.
Okay.
Any other questions for Mike?
Just so you guys know, like the amount of flow that's generated by, a non-rebreather mask at 15 liters per minute. A cough is around 200 liters per minute, and then someone sneezing is even higher. Like, I can't remember exactly how many liters per minute, but so those things don't really compare to the amount of aerosolization that's generated by those things. And the direction of those is really towards the patient as opposed to away from the patient. So
Anybody else got questions for Mike?
I have a question. Can you hear me?
Yeah, go ahead, Karen.
So I'm just wondering, kind of for the future, those models that you were showing us that showed the numbers going down to almost nothing in like June. But if we're taking into account that we'll probably be coming out of isolation and strict social distancing by then, are we kind of expecting numbers to go back up at that time?
my thoughts are yes, and some other models are predicting that with a peak in July or August.
Okay.
So I think that we don't know. This is an emerging infection. It has, compared to any other emerging infection in modern medicine, nothing has happened like this before. I mean, you could look at HIV for being somewhat similar, except that the communicability and how quickly people get sick and require intensive resources is very different. So this is something that's much more prone to community transmission with a higher requirement for hospitalization and intensive care use, and that's the real difference. Because you'll hear people say, well, this thing doesn't really have any different mortality than the flu, but that's in addition to the flu and a much higher requirement for ICU admission for other folks than influenza. So I think it's not comparing the same thing at all. The other difference is with influenza, we have vaccination that decreases the burden, as well as treatment that decreases the severity and some of the complications as well, where we don't have any of that right now. You'll see this stuff on the internet about hydroxychloroquine, which has really not been studied. And St. Patrick Hospital has inclusion for patients to be in a study for use of that, but it is not a panacea that's going to make people dramatically better. It does not work like antibiotics. And the other thing you'll see is remdesivir, which is antiviral medication that affects the ability of the virus to replicate. It again, super preliminary studies show that it may improve people in the ICU, but it's only it's only like a 50% improvement. And that's not randomized. That was in 60 patients. The data is super limited. A lot of this stuff, like practice in China, is all anecdotal. It says like, well, these people look like they might get better, but they weren't standardized. They weren't randomized. They, wasn't placebo controlled. So there's all sorts of problems with trying to interpret that.
Any other questions for Mike? Mike, anything else that you want to tell us about?
No, I think that right now it looks like we may just have kind of persistent low-level infections, which is going to be difficult for us to keep our vigilance up. So I would encourage people to, really consider this and use the PPE that we have right now. We look like we're doing pretty well for it. We have the ability to kind of use it right now to prevent transmission to healthcare workers, which I think is good. And if you're concerned, it's a little bit outside of the guidelines we put, and you use it, I don't think anyone's going to jump on you. So, and people right now obviously are under a lot of stress. So sometimes, be considerate to other folks who are dealing with this. You just imagine an emergency room where you're taking this stuff on 8 and 10 times a day, and you're in a room with a patient for 40 minutes at a time. So there's people are under a lot of stress with this right now. So
hey, I want to reach out. I know we've got Brad Davis and Jason Duffner from City and Rural. Are there things that City and Rural want to tell us or bring up while we have our group here?
Yeah, Dave, this is Brad.
Yep.
Just one thing I want to throw out there. I'm not sure if Sherry has reached out to you guys or not from dispatch, but with the governor's declaration early last week, we met with the county attorneys, I believe on Monday or Tuesday of last week, and got the okay to share patient health information with first responders and our dispatch center. And so what that looks like, any of the confirmed cases in the county will be shared with the dispatch center, and they're going to put them into the CAD system with a timer where they'll drop off after 14 days or upon further review if they've been cleared from that positive case category. And so if we get dispatched to any of those confirmed cases, they're going to mention that in the dispatch. For law enforcement, they have encrypted channels. There'll be more plain text, just letting those guys know that they're responding to a COVID positive case. For us, since we're not encrypted, it's going to be basically some sort of message in the digital page or over the voice page that will say refer to the narrative or refer to your MDT, and we'll be able to look on there and it'll say this address is flagged as a COVID positive case. So that was a big win for us last week, trying to get that information sharing with that protected information. So just be on the lookout for that. I know there's not a lot of active cases in Missoula County right now, so the chances of us getting dispatched to one are pretty low, but if we do get dispatched to one that's flagged, it'll pop up and just follow up on that 911 narrative for more information.
Hey, thanks, Brett. So is that, I don't know if I heard all that. Does that also include if the person has been with somebody, like there's somebody else in the house that has been confirmed to have COVID, or is it just for the patient?
Yeah, it'll be for both. So it'll flag the patient name and the address.
Okay.
And the health department will know, they'll be in contact with them, so they'll know what address they'll be isolating at. And so if we're getting dispatched to that address, it'll be flagged. So whether it's for a family member or that actual case.
Great. Brad, anything else on your city fire end that we should hear?
No, I don't think so. Just want to thank you guys for taking on this extra workload and with us staging and you guys being the ones to go in, kind of making that first contact on most of these. I just want to make sure that you guys know that we're grateful for that and don't take that for granted, and just wanted to say thank you. So, but that's all I really have.
Thank you, Brad. Hey, Duffner, you got something from Rural Fire that we should hear?
I don't think we have a lot, McAvoy. We been talking with Dr. Gilday quite a bit about the cardiac arrest, both medical and traumatic. it sounds like it's along those same lines of what Dr. Kremkau has been doing. The only thing that we've been talking about that Dr. Kremkau didn't mention was just we might put some age parameters on there as far as who we would try to run a little more aggressively than others. But we don't have anything finalized. If we do, we'll definitely let Dr. Kremkau and you know too as well, Dave. But yeah, it's all the feedback that I've been getting from our guys is that you know, the scenes have been running really well, that we've been working well together. So super encouraging, and yeah, hopefully we can just keep that up. But that's all I've got. Thanks.
Thank you. Hey, Mike, there's a question from Ungaretti, which says we're noticing a shortage of LR. Is that a preferred fluid for COVID?
Honestly, again, I'm trying to restrict fluid to these patients.
Okay.
We're literally, how that works in the ICU, just so everyone's aware, we try and not give them any maintenance intravenous fluid, so they're just getting fluid from the infusions for sedation or vasopressors. They're monitoring their ins and outs to have them even to slightly negative every day. And if they're not meeting that, they're putting them on Lasix. And if they can't, if their creatinine's rising or they're not able to maintain that with Lasix, they're actually putting them on continuous renal replacement therapy, which is like continuously running dialysis to maintain that even to slightly negative balance. So we actually, in the emergency room, kind of took the fluid resuscitation thing out of our sepsis team call. So, you know, again, I would, you know, I think using normal saline is fine, actually, is the answer to the question, but we should, you know, be reserving that for patients we suspect are significantly volume depleted. You know, they've had like tons of vomiting or diarrhea. They haven't drank fluids for, you know, 24 hours. Or patients who have, you know, low blood pressure, so systolic less than 90 or less. So.
Okay, thank you. Anybody else have any questions?
I have one question. So outside of city and rural, Dr. Kremkau and Dave and everyone, you guys have been coordinating with other agencies that we work with. Are like, you know, there's definitely changes in our patient care. You know, it seems to be more BLS and ALS that we could, you know, especially with like respiratory COPD-ers. So is that kind of like an ongoing discussion with other agencies outside of Missoula County? Does that make sense?
Yeah, I mean, I have not done a great job. I know Bob has reached out a bunch, and I'll let other people just speak to that. I haven't done a great job with that, Kath. I know that. So.
Or you're fired.
Yeah.
I was just curious because we, you know,
one thing in there about there's concern that, you know, not giving a nebulizer treatment isn't the same level of care, and I've heard this, and not specifically for you, Kathy, but just sort of people brought this up, is that it actually has been shown to deliver as much medicine and maybe deliver it more effectively to the small airways. And that's by using that 6 to maybe 8 puffs in the air chamber. And the reason that is, the nebulizer develops relatively large droplets, and those large droplets kind of come out of in the larger airways rather in the smaller airways, and that's why you're giving so much more medication per milligram dose through a nebulizer than you do through an MDI. So when you're doing an MDI, the particles are so much smaller that, you know, fluid dynamics that occur in the airways help deliver those smaller particles to the smaller airways more effectively. So the reason we don't do it all the time is, you know, there's more cost associated with it probably. That being said, I think in hospital studies where they do this, they've actually shown better compliance with using MDIs at home and lower risk of emergency room visits, because people realize that if they're using their MDIs appropriately, they don't necessarily need the nebulizer treatment.
Awesome, Mike. Anybody else? All right, Mike, thank you very much for getting this going here. I will post, this is all being recorded. I've got it on a LAD Tech. I'll get it up on a LAD Tech here soon. Mike, thanks again. Thanks everybody for chiming in. Appreciate everything.
Thanks, Dave. Thanks, everyone.
All right. Take care.
Thank you.